Okay, hello everybody. Welcome to another World Patients Alliance webinar. This webinar is on World Patient Safety Day. My name is Andrew Spiegel. I'm the current board chair of the World Patients Alliance. Along with my fellow board members, we welcome everybody to this really important webinar. Next slide. Keep putting in the chat your name and where you're from. We love to see where everybody's from. I want you to know that if you don't have English as your first language and you prefer to watch and listen to this interpretation in your own language, we have more than 50 languages with Wordly. If you look in the chat right now, the office has put a link in there. You simply click on the link, you pick the language that you want, and then you'll hear and see everything in your own native language. Next slide. So real quickly, just a quick overview. Most of you know who we are, but we are the world's largest umbrella organization working across all diseases. And our goal really is to make sure that the patient is at the center of all healthcare discussions. And we work to ensure that patients have an active role to play in all stages of healthcare, everything from the beginning and the planning and the provision of healthcare all the way through the monitoring, research, and evaluation. Next slide. There are no fees to join, so if you are a patient organization and want to join us, just go to our website at worldpatientsalliance.org, fill out a membership form, and that will go to the membership committee. We have just hit 700 members. Congratulations to everybody working on that. We now have 701 member organizations from 137 countries. So good job, everybody. Next slide. So today we're going to be talking about World Patient Safety Day, and there's nobody better to talk about that than Helen Haskell, who frequently shares her personal story as well as all of her decades of experience on World Patient Safety Day. She is going to run this entire program. So Helen, I'm going to turn things over to you and you can introduce yourself and take it away. Thank you.
Well, thank you, Andrew. Next slide, please. So I'm Helen Haskell. I am chair of the Patient Safety and Quality Council at World Patients Alliance. I'm a longtime American patient safety advocate, and I am pleased to moderate our session today on pediatric safety in honor of World Patient Safety Day 2025. So we've got a full agenda, as you can see. We've got really some notable speakers in global pediatrics and patient safety. We're going to start out with Dr. Blerta Maliqi from WHO, who's going to talk about World Patient Safety Day and the things that WHO is doing. Dr. Peter Lachman, who is another global pediatrician, will talk about his SAFE program and situational awareness and give us some background on pediatric safety in general. And then Dr. Isabella Castro, who is a Brazilian dentist who lost her infant daughter years ago to poor patient care in the NICU in the hospital. We'll talk about her experience and the lessons learned in her experience as a patient advocate over the subsequent years. And then we will have a panel discussion with all our speakers and questions from you, the audience. Next slide, please. So I just want to talk a little bit about why we're here. This is personal for me. My own son, my dear son Louis, died in a children's hospital almost exactly 25 years ago. And it's long been clear to me that at least part of the reason for his death was that even though it was a children's hospital, the people who were supposed to be taking care of him did not really understand pediatric care and the ways that children's medical conditions differ from those of adults. And this is really disturbingly common. For years, I began my talk with pictures of children who had died from medical error, and there are many of them. I'm not going to do that. This webinar is about action and hope for the future, but I do want you all to remain cognizant that the stakes are high. So next slide, please. So in honor of this World Patient Safety Day, we're celebrating the accomplishments of pediatrics. In many ways, pediatrics has been the leader in patient safety, especially in patient and family engagement. Some of the most prominent early leaders in patient safety, the people who began it, like Lucian Leap and Don Berwick, were pediatricians. Pediatricians have led the way in work on communication, on handovers, on family-centered care, and that includes family-centered rounds, family escalation of care, and as you'll hear from Dr. Lachman, situational awareness, which is being vigilant about what's going on without being told, which is especially important when your patients can't always talk. Next slide, please. I just want to talk about a few of the things that World Patients Alliance has done for this World Patient Safety Day. We have partnered with the publisher Elsevier to create the Doctor Safety series of children's books on patient safety. They're available on our website as printable downloads, as flip books, as audiobooks. And they've been translated into, I believe, 5 languages at this point, with more to come. Next slide, please. And this is the link that you can go to. So we already have a patient safety bill of rights on our website. And to go with that, we have created 2 new patient charters, especially for children and families, for parents and children. They're mirrored. Next slide, please. Just to show you some of the content, things that are especially important for children and families that are not necessarily included in our general patient rights charter. So next slide, please. And we also have a video called Children Are Not Little Adults, Understanding Patient Safety in Pediatric Care. So we will play our video for you now, and then we will begin our program. Next slide, please. Can you play the video, please?
Yeah,
Eric?
Helen. Yeah. Just some small technical issues, just bear with us.
Children are not just little adults. Children are very different from adults, especially when it comes to healthcare. Their bodies and brains are always changing because they are growing. They have different needs and different patient safety concerns at different points in their lives. Did you know? Newborn babies breathe 5 times as fast as adults. Their hearts beat twice as fast and gradually slow as they grow. Parents and healthcare workers need to be aware of the expected range of vital signs for the children they care for. Children absorb medicines differently from adults. This puts them at risk of unwanted side effects. Medication doses need to be tailored to each child's age, weight, and health status. Some medicines are not safe for children at all. Children are more vulnerable to disease because their bodies have not yet developed resistance. In addition, their small size means they can easily become dehydrated. Illnesses affecting the lungs can be more severe in children because their airways are small and easily clogged. How can you keep your children safe and healthy? Children should have regular health checkups and receive all recommended vaccinations to protect them from dangerous diseases. Know when an illness might be serious. If a sick child does not want to eat or play, will not stop crying, or has little urine output, it is time to see the doctor. To learn more, visit the World Health Organization World Patient Safety Day website or visit our website www.worldpatientsalliance.org, the global voice of patients.
Thank you, Harris. Now we will move on to our first speaker. Next slide, please. So I am honored to introduce Dr. Blerta Maliqi, who is the head of WHO Patient Safety and Quality. I am not going to go into people's bios in depth. They are on the website if you want to see them. But Dr. Maliqi is a medical doctor and has a PhD and has been a global leader, really, in initiatives to improve the quality of care for maternal, newborn, and children. And she's worked with governments, frontline healthcare workers, and international partners in pursuit of that goal. So I'm pleased to have you here, Dr. Maliqi, and I'll turn it over to you.
Thank you very much, Helen. Helen, can you give me a thumbs up that you hear me correctly?
Yes, you sound good.
Thank you.
Next
Thank
slide,
you.
please. Yeah.
Next slide, please. Thank you. And thank you for inviting me and WHO in this very important webinar. Thank you for giving me the floor immediately after this wonderful video that explains so well the purpose and what is it that we would like to achieve through the campaign this year on the World Patient Safety Day. Next slide, please. So in the next few minutes, I would like to cover a few issues. Why quality and why safety? Say patient safety for all and everywhere. Why pediatric and newborn safety this year? And what is it that we would like to achieve through the campaign? So allow me to start from the very beginning. Patient safety is a massive burden. In patient safety and unsafe care are a massive burden in the health outcomes. By now, we know that 1 in every 10 patients is harmed in healthcare. This results in more than 3 million deaths annually. That is, we know that 50% or half of the harm is preventable. And what we know also, it is that in low and middle income countries, 4 in 100 people die from unsafe care. So this is a massive burden. It's a massive burden, it's a health burden, it's a family burden, it's a community burden, and it's a burden also that has a very important economic impact. It's important to talk nowadays on the economic impact because everybody's life has value, but everybody's life also has an impact in what we're trying to achieve, improve health for all. Direct costs in high-income countries is up to 12.6% of total health expenditures. That is about 878 billion annually. So unsafe care has a high cost, perhaps the highest cost in the healthcare and what we are providing today. Indirect costs, unsafe care reduces productivity and increases income loss. So if we're moving into improved safety, and if we manage to improve safety, we can see a profound economic benefit that can potentially increase the global economic output by 15% after 2 decades. So investing in safety, it is most likely the best investment we can do today in healthcare. Next slide, please. With this in mind, I would like to draw your attention in the Global Patient Safety Action Plan. This action plan is a result of WHO, the World Health Assembly resolution, and that resolution calls for action in all countries to improve care. One of those core actions, as you'll see there in the very first strategic objective of the framework, is about celebrating the World Patient Safety Day everywhere, in every country, every year, and then within that, setting a new challenge. Next slide, please. We have started to celebrate World Patient Safety Day since 2019. As such, every year there was a new topic that surfaced to respond to global priorities and to respond also to those priorities within safety that sometimes are silent but are as important as anything else. So this year's, next slide, please. The priority for 2025 is World Patient Safety Day for newborn and pediatric care. I'd like to draw your attention that each country every year imagines on how to proposes new ways to celebrate the day. However, the symbol of the Patient Safety Day is lighting a national monument in orange. So we're looking forward to seeing as many monuments lighted in orange as we move towards the 17th of September. Next slide, please. So the World Patient Safety Day 2025, the theme is safe care for every newborn and every child. The slogan is patient safety from the start. Helen already built a case why this is important. Next slide, please. However, I'd like to just pull together some of the data and the evidence that made us think through and put this as a priority for this year. First of all, children are not small adults. So Helen already said that. Adverse events are higher in children. And those are similar maybe to those that adults suffer, but they are specific to them. So healthcare-associated infections, medication-related errors, surgical-related errors, pulmonary-related conditions, medical technical product-related errors are very common in children. So based on the current evidence, we can now say that studies report rates of adverse events as high as 90.6% in pediatric intensive care settings. And that is compared to 53.8% in general care settings. That means that almost every child that goes through an ICU has or suffers an adverse event. Half of children who go through pediatric care face an adverse event. So this is a very high impact in terms of health outcomes, length of stay, complications, and some of them finishing or ending in tragic outcomes. So we have really to pay attention to adverse events that are as a result of safety issues. 1 in 6 patients in pediatric ICUs experience one or more adverse drug events. So we even know a bit more about what is happening in ICUs, with an incidence of 16.7 per 1,000 patient days and more than half of adverse drug events are thought to be preventable. So we are really in front of a fact. We are providing children with care that should be the right care, but we're providing in the wrong way. And we're even giving them, most likely, drugs or medicines that are not correct for their age, they're not correct for their conditions. And we know that half of those conditions that we are creating can be preventable. So are as a result of an error or as a result of something that we are not doing well. In neonatal ICUs, and now we're moving into even a more specific group of children, so neonates. Very difficult to understand how neonates are. They don't have the gift of the word yet. The only way how they communicate is through their parents, through their mother, through their caregiver. And they have to be really very, very careful in understanding the signs. Not every mother understands all the signs. So what happens in an ICU when the baby is underweight, has been born earlier, and requires specialized intensive care? Between 0.7 to 2.4 adverse events per admission, and that is important, is per admission, have been reported in some studies, with 56 to 97% of these events being preventable. Medication error rates range from 4 to 35.1 per 1,000 patient days and from 5.5 to 77.9 per 100 medication orders. And then finally, rates of acquired infection in neonatal units have been estimated anywhere between 15 to 62% per 1,000 patient days in neonatal units, with the highest rates in low and middle income countries. So I've seen that people are coming from very different parts of the world. This is a problem that is a generic problem, generalizable in all settings, but low and middle income countries are suffering more. Generally, we know that we can save 1 million newborns with improved quality of care, and that we can really improve hospital or address hospital-acquired infections that can account anywhere between 4 to 56% of deaths in neonatal period. And that patient harm is more preventable in children with special medical needs and relying on medical technology. Again, not very surprising if we think about the ICU outcomes that we have as a result of errors. Next slide, please. Now I'll go a bit faster so we understand why this is important. This is a problem that has been there for many years. The Sustainable Development Goals have embraced the health of every woman and every child. There are two goals that have been put there forward to the humanity, and that is on the survival. Child survival with a focus on newborn survival are very important, and that is why there is a global strategy for women's and children's and adolescents' health that talks about surviving, thriving, and transform. And within that, there are a number of international mechanisms or strategies and plans that allow for their implementation. Among them, Every Woman, Every Newborn, Everywhere is one, or EWINI is one of the big strategies. Child Survival Action Plan is another strategy that are focusing on pediatric and newborn care, and they are looking at safety and quality of care as their priority strategic objectives. Next, please. So these strategies are not coming out of the blue. So it's not only about saying we would like to improve and how. They have embraced at the core quality and safety. The WHO framework on quality of care is based on provision of care, or considers both provision of care and experience of care underpinned by the health system's functions, with safety at its core as the way to go forward. So as the way to organize service delivery, to support those service deliveries, and then to make sure that everybody receives the correct care, safe care everywhere. Within that, the one parameter that is very important is the engagement, and is the engagement of not patients, but let's call them children and their families. Their caregivers, the designated caregivers, whoever they are, who very often speak on their behalf. Important as this translates into very specific standards for safe care. Based on this framework, there are three sets of quality of care standards that have safe care on their heart: the maternal health standards, the newborn health standards, pediatric care standards, and those standards that are for small and sick newborns. Within and across those standards, there are 5 themes that come very clearly forward: engagement of children and families, medication safety, diagnostic safety, prevention of hospital-acquired infections, and small and sick newborn as a specific group that requires specific attention when we discuss patient safety. Next slide, please. With this, we would like to go into what we have described and then made available to the world, which is a summary of these, well, let's say, well-intended standards in a language that is understandable and translatable into action for everyone. And those are what we call the Patient Safety Day goals. So 17th of September, Patient Safety Day is coming. That will be, the theme is on neonatal and pediatric care. And for that, we have set a number of goals. Why goals? Because that is a call for improvement that is aligned with the theme. They do focus, the goals focus on the high priority, risk-prone or high impact interventions. From a WHO perspective, they are all actions based on existing guidance, guidelines, and recommendations. They target mainly healthcare facilities and providers. And why facilities and providers? Because that is where the first interaction happens, where we ensure that quality and safety are in place, and that they are supported by outcomes and process measures in order for us to understand. So while this is in general, next slide, please. This year's safety goals are, as we said, on newborn and children. We have analyzed and identified those 5 goals that look across the 5 domains that I already presented. So engagement, medication safety, diagnostic safety, prevention of healthcare-associated infections, and the target group of and risk around small and sick newborns. Now, those goals are available in the website. Next slide, please. And everybody can go and see them as we are discussing. Those goals are, in order to make them actionable, all goals have been described across 6 categories. So people, what is that people need to do, what the healthcare workers have to do, the skills, knowledge, attitudes, training that they need to have in place to deliver on those 5 goals, the tasks that they have to undertake, them and their institutions, the tools and technology that is needed to support them, the organization of the workspace environment in order for them to deliver safe care, the organization capacities and characteristics that facilitate that care, and finally, how to measure. So for each of those 5 goals, next slide, please, you would be able to see everything around those 6 dimensions. And each of the goals is supported by the references and the resources from WHO in terms of pediatric newborn care, safe care, and everything under each of the categories. I will not go into details for each of the goals. I would like only for you to see through the screen, and then we'll put the link in the chat so you can go and navigate and commit to them. But as you see, they are very specific, very simple and specific. And the reason for simplicity and specificity is that I would like for these goals to talk to every environment, including those low and middle income countries where the impact is highest in terms of the unsafe care. Next slide, please. So engage children, parents, and families. Next, enhance medication safety. Next, please. So diagnostic safety. Next, please. So healthcare associated infection, their prevention. And the last one, small and sick newborn. Next slide, please. What do you do with these goals? So how to use them? First of all, please look them up, sign up, and say what is it that you can do from your perspective, from your setting, what type of action you can take. Adapt them to your context, to your services and resources. Integrate them as part of the ongoing, if you are in countries that are part of the WINI Child Survival Action Plan, do include them in those global strategies. If not, please do include them in every single strategy and action plan that talks to this target group, that talks to patient safety. Prioritize based on greatest risk and more urgent needs. So look at the all goals, pick up the goal that talks more to your setting, use that goal to improve. Encourage health facilities to embrace them. When we know that health facilities are implementing and aiming to improve across all these 5 very broad goals, encourage them to prioritize and implement them. Implement these goals through teamwork, systems, and supportive culture. Measure the performance, understanding where you were at the beginning and where you're going as you improve. And improve by learning from practice, feedback, and innovation. None of us knows exactly how to improve every single thing. All together, if we start exchanging our information and learning, we will improve faster and learn from each other's improvements. Sustain these goals by embedding them into the routines and continuous monitoring, and please share the learning and best practices. Next slide, please. The World Patient Safety Day is on the 17th of September. As everyone in the patient safety community says, it's not about one day in the calendar. It's about action and improvement every day, every minute of the year. It's a non-stop activity that requires support. For that, we are not able to do it alone, so that's why we highlight the teamwork and the learning, but we need the help of everybody. We need the help of the advocates and activists. We need the help of the scientists and researchers. We need the help of those who are able to communicate with everyone. We need the help of communities, of families, of patients, of people who have suffered injustice and unsafe care, and those who have helped them to move together. It's only like this that we as health sector and health providers can improve and reach the goals. So please advocate for policy and regulatory actions to embed pediatric and newborn patient safety in national strategies and action plans, build the capacities of the workforce in risk management strategies and patient safety practices. Do strengthen patient safety, especially in high-risk clinical processes. We started with ICUs as we started to build the case. And then please look across the key safety issues. Promote a strong safety culture across all healthcare organizations, strengthen reporting and learning systems, enhance patient and family engagement, and strengthen research in patient safety in pediatric and newborn care. We do need to strengthen research on patient safety and then specifically on newborn and pediatric care. This is very important for all of us. Next. Please scan the code. Please go into the website. Please register for the goals. Please tell us what you could do so we can understand and learn. And also, please join the community of practice on patient safety, because that is where we can all start to exchange, learn, and beat the drum as we go towards the 17th of September. I think I'll stop here and I'd like to hand it over to Helen. Thank you, Helen.
Thank you so much, Blerta. That was a wonderful presentation. I should add, please put your questions in the Q&A box so that we don't miss them. We will answer all the questions in the speaker panel at the end. Right now, we're going to proceed with our speakers. And also, I put the link to the World Patient Safety Day webpage into the chat, but you can also just Google World Patient Safety Day 2025 and you will find these wonderful patient safety goals along with many other nice materials that have been created for World Patient Safety Day. So with that, I'm going to thank Blerta again and move on to Dr. Peter Lachman, who has been instrumental in helping develop some of those materials, especially the goals. He is a global pediatrician, works in a number of countries. He's a former head of ISQA and head of the Joe Kiani Patient Safety Fellowships at the Patient Safety Movement Foundation, and has published several handbooks on patient safety and quality that are widely used. So, Peter, let me turn it over to you.
Thanks, Helen, and thank you for inviting me. Blerta has really given you the global situation of patient safety, and I'll just start with a story because every pediatrician has a story of a child who may have deteriorated and died, and the parents would always say to them, "Why didn't you listen to me?" And I fortunately don't have any personal stories, but as a leader, I've had a number of times that I've had to sit with parents and they've said, I said to the doctors, my child's just not right. And in 1999 and in 2000, we had 3 children and I was working at Northwick Park. And each time when a child died, the parents in my meeting with them said, we told the doctors our child is just not right. Why didn't they listen? And these were fine doctors. I was at a unit where I had very good doctors. They thought they were listening to the parents, but they didn't hear. They may have listened, but they didn't hear what the parents were saying. The fact that the child was just not right. The one story I'll just tell you quickly before I start, because that child probably would be alive if we had the SAFE program, is where the parents said the child had cerebral palsy and came in with constipation, and the pain came and went, and whenever they examined the child, the abdomen was soft, the vital signs were normal, the child was just not right in the eyes of the mother. In constipation, you get constipation. In cerebral palsy children, you have constipation. That child went on the constipation pathway and saw 3 senior doctors, my senior registrar trainees, very good nurses, and on day 4 collapsed. And when they went to the operating room, they found he had a gangrenous bowel and he died. The child was just not right. The mother said the constipation is not the usual constipation. That's just saying it's not the usual constipation. What the child had was something called volvulus, where the bowel twists around on itself, twists, untwists. And the presentation was very typical, but the doctors had tunnel vision because they were on the constipation pathway. And whenever they examined the child, the abdomen was soft, so it wasn't a acute bowel or abdomen. That one stuck in my mind because when I sat with the mum and she said to me, I just don't understand why they didn't listen to me. Now, that was in the year 2000. I hadn't started on my patient safety journey. I had actually started my patient safety journey without knowing it. But there was no patient safety science. To as human, the starting gun of the modern patient safety movement had not been published yet. So we were still doing patient safety in the dark. We knew first, no harm. So let's go forward to 2014, when I now have been coming back from IHI in the USA. I was head of department I was head of patient safety at Great Ormond Street. And we were still having this problem of children collapsing and parents saying, we told you so. And the nurses might say, we told you so. So I thought about how can we make things different, and we came up working with Cincinnati Children's. We followed their lead on this idea that you have to have situation awareness for everyone. That's the acronym that we had on our program. It was funded by the Health Foundation and on the Closing the Gap program for patient safety, and was called the SAFE program. And so I'm going to just give you a high-level view of this. The idea that in order to know what's going on, you have to take everyone's view into account. Next slide, please. So next one, please. So just go back to the rights of the child. In 1980s, in 1988 and 89, Article 24 of the UN Convention of the Rights of the Child quite clearly states that every child has the best right to possible good quality care. I'd say if I wrote it now, I'd put quality and safe care if we rewrote the rights of the child. But this is the rights that most countries, excluding the United States and Somalia, have signed and held up to as what's required, that every child has the right. And the governments of each country have the duty to provide high quality care for children. And this is so important that we must remember that safe care is a human right. And that's why the rights that Helen's referring to are so important. Now, the other thing I would like to really stress here is that if we take this view that healthcare is a right, then maybe we'll think differently about how we provide care. Next slide, please. So these are the challenges that we face in children, and the challenges are very distinct for children. Firstly, as Helen said earlier, they go through different developmental ages. A neonate is not the same as a 2-year-old, 3-year-old, 4-year-old, teenager. They're all different. So of course we have to know different things. They're all dependent on adults. So they rely on us to give their protection and support and tell their histories and so on. As they get older, they can, but often people don't listen to them. The epidemiology keeps changing, and then finally the demographics. And you can just think about today of the children who are affected by poverty, wars in many countries, famine in many countries, natural disasters. The people who get affected the most are women and children, and of the women and children, if the women are affected, the child is inevitably affected, but generally the children are the most affected. So the 4 Ds are very, very important to remember, and that this is the foundation of all pediatric patient safety. Next slide, please. The next slide. We're a bit stuck here. Hello, can you change my slide, please?
Haris,
My slide hasn't changed. I'm still on the 4 Ds.
I know, I'm just asking, Haris is the one running it. Haris, is an issue?
Okay, so here in this slide that's coming up, you'll see
There.
what the problem is. This comes from friends of mine in Australia, the slippery slope. Now, I'm talking about deterioration here. What happens
Actually, there was an internet problem. I was going towards the next slide, but it was not moving. So
okay.
you want me to run this one?
No, we're on this one, please. Yeah, okay. On the slippery slope. Go back, please. Go back, please. Okay, now next slide. Okay, stop here. So here you see the slippery slope, and I use a slide from Australia, their Between the Flags program that they have, and I like this one because it tells you what really happens. Now see where there's a sudden deterioration. Well, in adults, they show their signs much sooner than children. Children compensate, and then they suddenly get to the cliff edge, and they just deteriorate suddenly. And the nuances of the signs are important. So often what will happen is doctors will watch the vital signs and they'll be normal, normal, normal. They'll be within normal range, and suddenly the child collapses. And then they'll say, well, what happened? And the parent will say, I noticed something was going wrong. Usually the nurse says, I noticed that something's going wrong, but the vital signs were normal because the child compensates well. So this is very important. And this is where we really want to do is have this review. You can see the yellow arrow and take the child off the slope into better care. So that's what we want to get them off the slippery slope to deterioration. And that's what deterioration is really we started with safe. Next slide, please. So here, Blerta told you about the challenges that we have, and the goals came out of all of, I put this here stressing that all the goals that Blerta spoke about come from WHO documentation and evidence. And you see right in the middle, I put medication safety because that's the highest risk. And we have a special huddle called the Druggle, which aims at that. But delayed diagnosis, misdiagnosis is very important. Newborns have the highest risk, just like the elderly in adults, and infection is so important. And there you can see they elevate the voice of the patients, and that is so important with children. Next slide, please. The other challenge is that we've been very successful in healthcare, so children are living longer. And because they're living longer, they have more comorbidities. Those with chronic diseases live longer, more comorbidities. We deliver siloed care, and the parents have to go with the child from one place to another. I had children at Great Ormond Street would see up to 40 different healthcare providers, and it was all not integrated. So non-integrated care is a big problem. And that's management of disease, not management of health often. The healthcare we've designed is not for safety. It's really not for that. And we haven't educated people for safety. And finally, I haven't given you the data, but the data for safety is very variable. And that's a big problem because it's so, there's no real definitions and good studies. We just know that we harm up to about 15 to 20% at any one time. I'd say it's about 20%, but studies normally show 10 to 15% of children are having some experience of harm somewhere in your hospitals or in your clinics in where they are. And it's quite frightening to know that. And we defined harm when we did our initial studies, anything you wouldn't like to happen to your own child. So of course the levels went much higher, but most people went to simple adverse events defined by healthcare, which is not what your own child. Next slide, please. So the SAFE program, here it is, Situation for Everyone, started in 2014, following Cincinnati publication of papers which I commented on. We got funding from the Health Foundation, and we ran it across 6 children's hospitals in the UK and 6 community hospitals, district general hospitals, for 2 years. And they were our laboratory. And after 1 year, we added another 18 hospitals. So everyone wanted to do it because they could see the benefits. So we went up to 30 hospitals, and then we went up to 50 hospitals. It eventually went on to 2018, just before COVID. And then in Ireland, I've been doing it with for the teams, not only in children, but with adult teams, obstetrics teams, and we've trained over 100 teams for the health service in Ireland. And the whole idea is to train people to be safe and to think safety. What Blerta gave you were the goals. The problem is implementation, and I'm going to talk about how you can implement the goals, and you can use any of the goals and use the SAFE methodology. Next slide, please. So it's quite simple. You can click through for these 4, please. The first thing is we have to understand risk proactively. So we're moving from reactive to proactive. That means we're trying to predict who may deteriorate, who may fall, who's at risk of medication harm, rather than reacting to the event, which is how patient safety started. Then we look at building reliable processes, and I'll show you a few things that you have to do. And that means that we standardize our processes and we do what we're supposed to do all the time. Human factors is the foundation of patient safety, and it's very complex. So we put it into the day-to-day work of healthcare workers. We use the SEEPS model, systems improvements in patient safety from Pascal Curran and her team, and situational awareness. And finally, we enhance the ideas, what they call safety 2, which is learning from what we do well and building resilience in the teams. Next slide, please. So let's look at situational awareness. You can just click here twice, please. In situational awareness is really where we gather information from the parents and families and the staff, and then we try to understand it. Click one more time. And from understanding that information, we anticipate what's going to happen in the future. So that it's really moving all the time, 3 times or 4 times a day, depending where you work, in an ICU, in an emergency room, is predicting what's going to happen and mitigating. So it's really getting an understanding of what's going to happen and then mitigating to prevent harm. And that's the whole thing. So people are talk about safety all the time rather than just reacting, which is the way that most people do. Next slide, please. So that's the theory. So this is how we get it. Firstly, we go to the parents and family and ask them, what's going on? Can you notice things that we're not seeing? Sure enough, they do. Then we ask the nurse, this is what's happening to the nurses, either the nurse or the doctors are doing this. Then they're asking themselves, what are we seeing? Because we see different things and nurses see different things from doctors. And then we go to the huddle with this information, and also just to say that, for example, some people have the dinner ladies, they may see the child's not eating as well as usually, a school teacher. We get as much information we have because everyone's got a view, but of course the parents and families are most important. And then they make a decision what we have to do to mitigate or escalate. Next slide, please. So here it comes again. If you click on each of these, you identify the problem. Early warning systems are going. I'll show you what an early warning system is. Family concerns, rising vital signs. The child just not getting better. When they say stable and they're not getting better, that is a problem too. A child is often in the wrong bed, and that means they're not getting the care they should get. And just the gut feeling, that's probably the most important one, from the intuition of the nursing staff or of anyone who says, this child's just not right. Then they go to the huddle, and this is all discussed, and they start predicting what's going to happen and escalate. And this will take for 15 minutes maximum for 20 or 20 children. They're just focusing on safety. We're talking about safety. We're talking about safety. We're not talking about diagnosis. That's a different process. This is about how safe are we right now. Next slide, please. So there's 6 questions we took from Charles Vinson's work, and I added one. The first one is asking, what do we do well? Because that's very important, because then you're learning from what you do well. That's safety 2 stuff. They call it safety 2, but I think it's just safety. Then they ask, have we harmed anyone in the last 6 hours, 8 hours? And that we started talking to people, what is harm? And there's another tool that we have in which we developed, in which we ask parents to identify the harms. And we're really looking at harm in real time, not in past time when things happen, but in real time. So did anyone fall? Did we give a wrong medication, et cetera, et cetera? Then asking about, are we doing what we're supposed to do? Are we following antibiotic guidelines, et cetera? Are we safe now? That is the human factors. I'll show you that. Will we be safe in the future? Is predicting the next 6 to 8 hours. And then most important, are we learning? If we're not learning, there's no point in doing this. And when the teams get adapted to this, they are now becoming a safe team, and they becoming part of what they do. Not something they do when something goes wrong, but they're being safe all the time. And fundamental to this is the parent. The parent is there in each of these questions. The parent is there, the child is there when they're old enough to speak themselves and speak for themselves. Next one, please. So here is the reliable. This is the high reliability, the 5 points of high reliability. The smallest errors are most important. If the prescriptions are wrong, you know you're going to have a medication harm. You just know you're going to get it. So you aim at getting 100% correct prescriptions. That's an example of preoccupation failure. And I'll just go to the bottom one, deference to expertise. The most expert person is the parent before they even start. So expertise is not professional clinical expertise. It's the person who knows the child best. Learning, knowing to the risks, and really knowing that the systems are quite complex, but always learning. So care reliable. The next one is the SEEPS model, which is, please, next slide, please. Oh, sorry, here's the reliability. I just jumped ahead one. So the one is if you're in ICU, you have care bundles, antibiotic use, clinical guidelines, sepsis identification. These are things that we ask people to discuss, all dependent. So they design what they have to do according to their context and who the patients and the children are. Next slide, please. The next ask is the SEEPS model, the situation model. And here we're really trying to build a team. And there you can see the work system. So when we did the goals, I was very keen to build human factors into the goals so that human factors are central to how you apply the goals. And then all there, you see the tools, organization, persons, environment that Blerta was talking about is home to the SEEPS model. The process of care is the reliability part, and they either get outcomes which are desirable or undesirable feeding back. And this is a learning system. Are we safe now? And we get clinical teams to ask this every day. Do we have the right staff? Do we have the right tools? Do we have the right patients? Are the children in the right bed? If we don't, what are we going to do about it? And they all do it in proactive way. The next slide, please. And the last one, here is safe in the future. And these are the ones that this is the early warning system that if you were on the call yesterday, Damien may have mentioned, this is from the UK, from England, the early warning system. And this is the direction of childbirth is the most important if the child is deteriorating. But you see on the red side, the most important one is family concerns right at the top. And then I've got all the other ones that are there. And as soon as any child has this, they're called a watcher, someone we've got to watch very carefully. And that comes from the US military, where Cincinnati got this idea. So this is based on the work in Cincinnati. So really, we're really asking people to predict, and then they're going to test their prediction on the next time, just like they do in quality improvement. Next slide, please, which is asking, are we learning? So they always have to ask, what are we learning? And that's building your safety culture. So if you go to the next slide, the next slide really tells you, my last two slides just say that the aim is to build a safe culture where people have psychological safety to speak up. In the huddle's just a tool. In a huddle, the hierarchy disappears for a moment. Sure enough, there's a leader, but the hierarchy is there. And that hierarchy flattens at the time of the huddle so everyone can speak up. And now you're building a safe culture. Because if you don't have a safe culture, all these goals that we've done, the strategies we've given, they will not work. It's all about culture. So what the feedback is, and if you want to contact me, we had embedded researchers when we developed it in the first 2 years from the Anna Freud Center, and it was action research. So for example, we had one researcher who was recording what was happening, how the nurses and doctors were speaking, and they finally discovered that nurses and doctors were changing their language. And language, of course, reflects your culture. So we think that this really, what it does do, it builds teamwork, it changes the culture, changes the way people think. And once you start doing that, it improves the outcomes because you're starting to predict. And I've noticed this with all the teams that I've worked, that we ask them to measure what's important for them, and they start reporting. We have earlier referrals to intensive care, we have less medication harm, we have less falls, et cetera, depending where they work. And it's quite phenomenal when I see what individual teams are doing. But most importantly, when we use the MAPSAP, the Manchester Patient Safety Scale, which is we measure culture before and after, we see the teamwork and communication just improves. And that's so important because every time I've done a serious case review, communication and teamwork has been one of the major problems. And part of the team are parents and families. And my last slide is, the next slide, is the whole aim is to make safety part of the genome of every healthcare professional. That means it's what they do. They don't have to think about it, that we have to do safety because something went wrong. We do safety because that's what we do. Thank you very much for listening to me, and I'm open for questions. And if anyone wants to implement SAFE, I'm quite happy to share everything for you because I believe that this is, of all the programs I've done in healthcare, if we can get clinical teams to be doing this every day and it doesn't take much time, there'll be a major improvements in healthcare worldwide. Thank you very much.
Thank you, Peter. Next slide, please. That was wonderful, Peter. Thank you so much. I feel like we have all really been educated in pediatrics, and I am very much looking forward to our next presentation, which is both the human aspect, the personal aspect from a mother, as well as the lessons learned by a longtime patient advocate. So Dr. Isabella Castro, she's a Brazilian patient safety advocate. Her journey began with the death of her daughter many years ago. She's engaged in many international organizations and has learned so much along the way and has so much to teach us. So with that, I am going to turn it over to Isabella.
Good
Next
morning.
slide, please.
Thank you. Thank you so much, Helen. Thank you so much, World Patients Alliance, for giving a patient representative a chance to share my story. As an institution that represents globally, the largest institution that represents patients, I think there should not be a better place for a patient to be in a day like this. Thank you so much. While I was listening to Peter, I was asking, what am I doing here? And I think you might be asking too, what is she doing there? And that is exactly what I'm asking myself. What I'm gonna say after Blerta, Dr. Blerta, Dr. Peter, but maybe it's time to reflect. We've heard from Blerta, who shared the perspective from WHO, which is a huge institution, the biggest one in the world. And then we've had the perspective from a great guy, someone everybody has a huge admiration, and someone who I have a profound love and gratitude, Dr. Peter Lachman. And I think, my dog also loves him, as you can hear. But now let's go beyond this and see what happens behind the curtains in care with patients and families and neonatal care. So let's see lived experience, how it is in the real world of infant loss and lesson learned. So today I'm going to share with you a journey of love and pain, the story of myself, Isabella, and my daughter, Leticia, that happened in 2006. It's a personal narrative about patient safety, maternal advocacy, and the journey of transforming pain into purpose. And the next, please. Well, who I am healthcare professional. I'm a dentist by professional. I have this background in healthy, and I discovered the importance of patient safety too late, unfortunately. And this is one of the reasons I feel guilty every day, and I still do therapy, and I treat this depression and anxiety, because for some reason I still feel guilty about Leticia's death. I got into this world too late. My professional experience gave me the insight, but not enough to protect my family. Because in 2006, I was just in my early career as a dentist. And as most of the dentists that I know, I knew dentists very much. I was a pediatric dentist, by the way, but I didn't know patient safety. But after 2006, after this eclampsia event that I had, and after Leticia's death, I don't know very well. It was not planned as most of the patient advocates, but I became a patient advocate. I got a member of multiple international advisory boards. I started to have a lot of curiosity attending my own patients. I started to see patients with special disease, cerebral palsy. I have a sister with cerebral palsy. I have a lot of curiosity. And especially I am human. I love to treat human. And I could see myself reflected in those mothers who were there. I could see them not just as a dentist. So that made me reflect and have more curiosity. And I started to travel abroad a lot. And with that, I channeled my experience into creating systemic change in healthcare system worldwide. That started maybe in 2012 when I got into Air Force and became a dentist in Air Force. And I'm also a mother, and that's why I am here. I am a mother of Leticia, my own daughter, my own special and beautiful daughter, whose brief life in 2006 forever changed the course of my existence and motivated me to fight for change and patient safety, and the reason why I am here today. And next slide, please. The harm experience. In 2006, I'm gonna tell you what happened. I was doing an exam in the State University of Rio de Janeiro, and I had a super pain in my head, and that was the first sign of eclampsia. I was pregnant of my newborn daughter, Leticia, and I suffered harm due to unsafe care. What should have been a celebration, in life became a cascade of preventable medical errors that ultimately led to tragedy. When I back to that year, I remember that I had harm during pregnancy, after childbirth, and during hospitalization of Leticia. During pregnancy, I remember that I showed a lot of signs of problems, that something was not going on during my pregnancy to the physician, but that was not considered. And you know what? First-time mothers, they have a lot of stigma because whenever we raise a concern, first-time mother, they make a lot of questions. They are very excited. They are so excited. They are so scared. Anything that happens, they think there's something, there will be a bad outcome. That is a problem because people do not consider our concerns, and we are there to the slippery, I don't remember the name that Peter, the slippery aspect, the beginning of the deterioration clinical thing. We are there to see this stuff, and people do not consider what we are trying to show. The first thing they do is to put us a tag, ooh, the pineapple. We become the pineapple patient at the corridor in the unit. So I show it. I don't have time today, but maybe in another opportunity, I show it and I try to raise I try to open even with no experience at all about patient safety, but I could see that something was not right with me. And today I know that I had clear signs of eclampsia, but I was not considered as a mother and as a patient. But then I was not considered. My early signs of the clinical deterioration were not considered. I had eclampsia. I got into that hospital. The hospital had no protocols at all. I remember that was on a Monday. I stayed more than 10 hours in a chair with dipirona, medication for pain, with clear signs of eclampsia. I could have died. I am here today sharing my story for a miracle. And that was in the morning, and they finally decided to give me a C-section under general anesthesia by the end of the day. And, they took the entire day to decide that. And another miracle happened. My daughter Leticia, she brilliantly made it to come to this world, and she was born healthy, and she went to the NICU. I remember when I woke up from the general anesthesia, I saw the team celebrating like a World Cup, and they were like a World Cup. I think I was very serious, and I might have been about to die. And a nurse came beside me and said, "Your daughter is healthy," and she went to the NICU just to gain a bit of weight because she's premature. And I was relieved and relaxed, and that was on a Monday. But the journey was the scary and shocking journey was just about to continue in the NICU. Next slide, please. We were surrounded by a system with systemic failures, and today I can see and I can share because I have studied, I have improved it, I have revisited this story almost every day in my life. I can hear the monitor of that ICU most of the time, even in nowadays. So I can tell you there are a lack of standardization protocols, the neonatal management, family participation at all. And the first thing that we think, we aim, our first reaction is to blame the teamwork. But the teamwork, I gotta tell you, they are also suffering, so as us families or more. So let's shift from rebellion to partnership, because they are in suffering as well, and they are in burnout. Instead of trying to blame the teamwork, we should try to look at the systems and fix the systems, because the physicians, they keep looking back into their career and thinking, why have I chosen, sorry, this career in the first place, to save lives, to help people, to relieve suffering. And they get up in the morning, have coffee, and they get in the hospital, and they are locked in a system that do not allow them to do so. So we should not blame people. We should look to the system, and together, allowing family participation in a proactive way, just like Dr. Peter showed it, allow patients and families to do active participation, not depending on the physician in the shift, because we have variation. The physician in the morning can be a person from Colombia, a person from Brasilia who is very compassionate and had a personal experience in the family. So he will always try to do something to allow the family to raise a concern. Well, but the physician on Wednesday is someone from United States who is also awesome and brilliant technically and on the personal level, but culturally it's a culture that's not so open, that does not hug, you know what I mean? So we should not depend on variation, and should not depend on the physician that is in the shift. We should create together systems that are standardized and allow a better care to be delivered with more compassion, dignity, respect, safety, and allowing patients and families to participate. And last but not least, communication. Communication is so important to allow people to say what's going on, because listen, you are not able to see what's happening full time, 24/7. With how many patients do you have in a unit? 20, 30, 10, whatever. Do you think you have a capacity to see what's going on? Isn't it good to have someone to tell you what's going on? Allow this, consider this, because this is going to help you. So patients, we are not visitors. We are not there to challenge the system, to revolt, to blame people. We just want to have a seat to help you, to help the team, to help the institutions, to fix the system, improve the care, and got better results. Next slide, please.
Isabella, I just wanted to say we've got 5 more minutes just to give you a heads
Okay.
up.
So sure. So the devastating outcome, I had a bad first day, a bad 2-3 days, and sadly, with that deterioration that was not considered, my daughter died in the ICU without having been seen, prepared, and involved in the process. We were denied the chance to fully understand, prepare for our present in the death. So each moment of those 4 days, it adds to my memory, a painful reminder of how quickly a celebration of new can turn into unbearable loss when patient safety falls. Next slide, please. The lasting impact, as you might imagine, we have the emotional impact, the relational impact, and the professional impact. There is this professional impact that you start working, you get in a new model of work, you start to speak about that, but it's never easy. We start preparation for that since August, because we know that September we have the Patient Advocacy Day. So we start in preparation with psychologists, because it's never easy to share the story, the relational aspect. I got divorced because the shadow of the death is always there between the couple. It's very difficult to remain married when a child dies, and there is always the guilty between the couple. Next slide, please. And I keep wondering, what if I had the knowledge and capacity, the technical capacity, cognitive capacity that I have today? What if I had this cognitive capacity in 2006, back in 2006? What if I had all this today? I could have done better. I could have done different, but I didn't. I got to know patient safety too late, but you don't. You can make it better. So what if there had been clear protocols in that hospital during my pregnancy? What if there had been standards of care? What if there had been family inclusion? So their questions are not just reflections of the past, of my past, in the past of my family, in the past of my daughter Leticia, but calls to action for the future of patient safety. Next, please. So priority, as Blerta said, Dr. Blerta, Dr. Peter, priority, safety of clinical practice, standardized protocols, patient participation might be a tattoo in our skin. Patient participation, allow patient participation, and education in systems at all levels. Next slide, please. I got to transform this pain into purpose. Otherwise, I think I don't know, I could have committed suicide, because that was very painful. That was extremely painful. I got into this international advocacy, committed leadership, and sharing my story for somehow helping people, help us advocates to share our own wounds. And I'm not sharing this to seem that I am a cool person. That really happens. You might have heard that from other advocates globally. So we do that because this is a way to keep us moving, to keep us alive. Next slide, please. Well, my call to action for healthcare professionals is keep doing the good work. Never stop believing in what you were doing, and challenge the system. Set up a meeting with your leadership this week. Do something better in the system, that fix the system. Don't give up. You can do something. Do not expect a great condition to do something. You don't have to be awesome. You don't have to be brilliant. You don't have to be Dr. Tedros. You don't have to be Dr. Peter Lachman to do something. You can do in your unit, in your hospital, in your community. You can start a change in your small level. And for patients and families, use your story to start the change. I could never imagine I could be speaking to how many people, like almost 500 people. I could never imagine that. But once you start, you never stop. And with that, I once again thank you so much for having me here. Thank you so much.
Thank you, Isabella. That was very moving and very informative. We are going to switch now to our panel discussion. We are being joined by Dr. Mona D. Shah, who was kind enough to join us from California at 4 in the morning. She is going to give us a little commentary on all of the presentations to open our panel. She's a professor at Stanford University and the chair of pediatric patient safety expert group at Roche Pharmaceuticals. So welcome, Dr. Shah. And
Thank you for having me. I am so impressed and inspired by these presentations. First of all, just a little bit about me. I'm a global health pediatrician and pediatric hematologist oncologist in practice for over 20 years. And I love, the talks and just how, engaged and the platforms that are being put together to assist our healthcare communities. I personally was so much involved and interested in this that I recently joined industry at Roche to continue this work, and specifically on the side of pediatric safety and managing the challenges in drug development and making sure that any new medicines that are being developed are actually safe for our most vulnerable patients. I really want to thank Dr. Haskell and Dr. Castro for being so vulnerable and sharing their personal stories. It's very brave, but it's so important. And I think that you really kind of hit home on the topic of, teamwork. We always talk about in pediatrics how it takes a village to raise a child. Well, it also takes a village to ensure that we are not just treating disease, but also ensuring that any sort of preventable harm, is preventing us from losing a patient, which no pediatrician ever wants to do. Dr. Maliqi really showcased the support and the messaging that the World Health Organization has put together and resources that can be accessed. And again, there's the themes of advocacy and teamwork. And then with Dr. Lachman and the 5 Ds, I think those really hit home. And particularly his message of not just hearing, but really listening and engaging with families. He actually reminded me of some cases of my own when nurses and parents had come to me and said, something just doesn't feel right, and believing them and letting them know that we do believe them. We just will figure this out together. I really hear your themes of placing not just the patient and the family at the heart of what we do, but really making sure that the multidisciplinary healthcare team, the teachers, the housekeeping, the medical technology world, the drug development world are really all engaged together to ensure that we're really providing safe care for every newborn and every child. So thank you so much for putting these amazing talks and resources together.
Thank you, Mona. So let's get to some of the questions. My burning question for Peter is what do parents need to know to apply situational awareness to their own situations? So how can they be the best observers of their children? How can they provide better information to the healthcare team and help their children the best they can?
Well, Helen, the role of the parent is to protect their child. I think that's the first thing. And parents, often the doctors will say, this mother's neurotic. And I said, no, mother's never neurotic. The mother's just concerned about her child. And if you ever do not listen to a mother, and I must just say, Margaret Murphy, who you know as well, said, never disregard the words of a mother, even when the child's an adult. And that was the story with her child, who was an adult. And they disregarded her word. The first thing is that, and I put it this way, in a hospital setting or in a clinic setting, doctors visit the child on rounds. They see the child once or twice a day. The nurse spends time with the child. The mother's always with the child and knows the child best. So, who has got the most information about the child? It's the mother. Then comes the nurse, and finally the doctor, who relies on these empirical vital signs that only deteriorate at the last minute. So every time when I listen to, and it's very sad to me because, as you know, with Martha's rule in the UK, that rule it's not a rule that's really needed. It's really about everyone should be able to listen to parents. But the problem is that there's a power differential in healthcare. And healthcare has the doctors having all the power. And the patient is at the parent and the patient are at the bottom of this power differential. And so what I really think about is in the teams, what we talk about, and we talk about this openly in the SAFE thing, is how can you get rid of this power differential? Because everyone has their own set of knowledge, and parents have their set of knowledge. They know their child, what their child is like. And so how do we do this? Well, clinical teams, first of all, have to start talking about that with parents. Look, we're going to ask you to tell us when you think something's not right. That is the psychological safety for parents, where the doctors and nurses are showing their vulnerability. We may not get it right all the time. After all, the experts here are the parents. Now, that's quite a mature team and takes time to get there from the hierarchical process that we've got right now. But the SAFE program is aiming to equip parents as well. So the clinical teams now start talking safety to parents, say, look, over here, you're the experts. We're not the experts. We know about clinical disease. We know. So Mona's an oncologist. She knows how to treat the cancer. The mother knows about the child's reaction to the medications, the reactions to the drugs, what's happening. The mother knows that, but Mona doesn't. That kind of thing. So you can see the issue is these two can come together. So now we get into this idea where we are not providing a product, we're providing a proper service. And the services are based on relationships where two people come together as equal partners, co-producing health. And
Thank
this
you.
is what we want to do.
Thank you. Thank you. So now I have a question for Blerta. This really came from Mary, but the question really is how can these goals be applied in low resource settings? What do you do when there is no health center, when there is no water? What do you do?
Yeah, thank you. Thank you very much, Helen. And I understand the question and Mary's concern. First of all, as the world is advancing, there are now fewer places that are really facing the extreme conditions of no service availability. In fact, now we are moving towards another extreme, which is services are theoretically available, but they are not functioning. And that means that they don't have water and sanitation, that they are not staffed with the adequate level of staffing or staff who has the skills to deliver on the job. They are not supported all the time with the drugs and commodities that they need. And of course, at the end, the organization is not functional because they are not able to respond to the needs of their communities that they are serving. So the point today is not that much about how do we make services available, but how do we make these services to be functioning at the quality and safety level that is required. And that is why we're having this massive problem in safety. Those countries that have low resource settings, that are operating basically with low resources, that they belong to low resource settings, while they do have a lot of issues in relation to what is available, they also have a lot of solutions on how to make them functional. So how do you translate such a goal into an operational system in a low resource setting? Please, first of all, prioritize which goals are more relevant to you. And prioritize them not only in terms of problems, but prioritize them also in terms of solutions. You may have settings in which the communities are better engaged with the health facilities, that they understand the needs of the staff, that they create the minimum conditions for living, that they can make sure that the water and sanitation is in place. So please do engage or highlight or prioritize that goal that can really respond to your setting. Do look at the alliances, build partnerships with those who are able to support, especially when it comes in terms of competency development or training, not only on resource allocation, but on that kind of skill that is necessary to deliver correctly the care. So we have the two goals that are around diagnostic safety and medication safety. Those depend on the skills of the staff, on the organization and the teamwork, on the ability of that organization to network with other organizations that may have those capacities in place, and that they can learn from each other as well as they can make resources available from each other. And then when it comes in terms of the goal on newborns and small and sick newborns, please don't look at shortcuts. We already know that kangaroo mother care, for example, is one of the core interventions that works and works very well in all settings. So please do adopt those evidence-based interventions that operate in all settings, but going into there are no shortcuts, there are no shortcuts. Small and sick newborn, they require specialized care. They require what we call now level 1, level 2 facilities or level 3 facilities that do provide the full scope of care and service and support to the families. Saying that, I don't want anybody to be scared. Those are types of services that must be made available. So please advocate, please engage with your health facilities and health providers. Please help them to build the case, because when the voice of community is built with the voice of providers, it becomes stronger. And that is when the politicians and policymakers, they move and make services available where they belong. But we must also make sure that what we're making available is not just available, just a tick in the box. It has the quality and safety that it requires. So yes, use them as a checklist to prioritize. Use them as a checklist to start telling your story and to guide your story. Use them as a checklist not only to address problems, but also to identify and prioritize solutions, because then you can build from somewhere better than where you are currently.
That's great. Thank you. Thank you so much, Blerta. And we have one last question. Very quick, Isabella. Tell me the steps that you think healthcare systems could take today to ensure that families are partners in care. So what are the challenges and what are the possibilities for co-production in 30 seconds?
A lot of questions in one. I think a good starting point is to create a patient and family advisory board. You don't need to be in a hospital. You can be in a primary setting. You can be in a board. You can be in a health insurance, but open nominations for PFAC, Patient and Family Advisory Board, is a great way to have first thoughts, to have the patient perspective in the building the process of the institutions. Peter and I, we had the opportunity to do that International Society for Quality, ISQA. We were having a coffee in IHI, and we opened nominations, and we were surprised that there were a lot of people trying to wanting to participate on that. And we were not in a hospital. You were in a board. So this is it's a very it's a very nice way to start, and it
Thank
makes
you, Isabella. I think we need to stop there because
yeah.
we do have to close. I really appreciate it. So I'm going to turn it over to Hussein to take us out. And thank you all for attending. I think it's been a very productive webinar.
Thank you, Helen. I'm very happy with the webinar today. I really would like to express my sincere appreciation to our distinguished speakers and panelists, Dr. Blerta Maliqi, Dr. Peter Lachman, and Dr. Isabella Castro, and Dr. Mona Shah. And last but not least, Helen Haskell, our very beloved Chair of Patient Safety and Quality Council. I'm also extremely grateful to all the participants who join us from across the world. Your engagement and contributions have really made this session very impactful. Today, we focused on World Patient Safety Day 2025 and its theme, Safe Care for Every Newborn and Every Child. And thank you for WHO for highlighting this very important issue globally. So similar to previous years, WPA is organizing a massive global campaign through our members in highlighting and promoting this year's goal of the theme. And I invite you to please continue this journey with us. And as Helen mentioned, WPA has developed 2 bills of rights for this year campaign. The first one is the Bill of Rights for Parents and Caregivers of Children, and the second is the Bill of Rights for Children. Please use these bills of rights in your campaigns. Then, with the knowledge, right knowledge and support, we can prevent harm before it happens. And that begins with education. not just for the healthcare providers, but for the families, parents, schools, and children themselves. And this is why early education is so important. And at the World Patient Alliance, we're very proud of our patient safety books for children developed with ELSAFE Foundation. So we are very pleased that these books are currently being used by a number of healthcare stakeholders in their campaigns. Please share these patient safety books with your network, integrate them into your World Patient Safety Day plans this year, so children and families see this messages everywhere. And I would also like to extend our deepest gratitude to Roche for their very kind support of the World Patient Safety Day 2025 campaign that actually enables us to advance this vital mission. And once again, thank you all, and I really look forward to welcoming you again to our upcoming programs. Thanks and bye. Thanks a lot.
Thank you. Thank you all.
Thank you. Bye-bye.
Bye-bye.